Welcome to the deep dive. You know that feeling when you have to process a stack of complex academic research before a big presentation or meeting?
Uh-huh.
Today, we are basically shortcutting that process for you. We're diving deep into one of the most foundational sources in psychiatry, Kaplan and Sadock's comprehensive chapter on attention deficit disorders.
Yeah, and our goal here is really to pull out just the core insights on the history, the diagnosis, what causes it, and, how it's treated across the lifespan.
Exactly. We want to turn this, let's face it, pretty dense textbook chapter into something you can actually use, a fast-track briefing.
Right, so you walk away with a clear picture of ADHD, from the brain circuits involved all the way to managing it day to day in kids and adults.
And this is a huge topic. I mean, the scale is staggering. It's the most common childhood behavioral disorder seen in U.S. outpatient clinics.
That's right, and the numbers back that up. If you look at studies like Polanski's or Willicott's, worldwide prevalence in kids is somewhere between, say, 5.3% and 7.1%.
But here in the U.S., it's even higher. The 2016 National Survey of Children's Health found 9.4% of school-aged kids had an ADHD diagnosis.
And that difference, it's generally thought to be more about awareness and access to diagnosis, not necessarily that the condition itself is genuinely spiking more here.
Okay.
But what's really interesting is the journey to even get to this point of understanding.
Yeah, tell us about that history. It wasn't always called ADHD, was it?
Oh, definitely not. I mean, the first descriptions go way back to 1902. George still talking about these really restless, impulsive kids.
Okay.
But early on, especially in the 20th century, it got saddled with some, frankly, pretty heavy and inaccurate labels. Like after the encephalitis epidemic around 1919, 1920,
Yeah.
kids with similar behaviors were often labeled with minimal brain damage syndrome. Really quite stigmatizing.
Oof, yeah. Minimal brain damage.
Yeah.
That sounds bad. And it assumes a physical cause that wasn't proven, right?
Yeah, exactly. It got a little softer later, minimal brain dysfunction, but still not great. It wasn't really until the DSM-III back in 1980 that things shifted.
Ah, the DSM-III.
Yeah, that's when we got the term attention deficit disorder. And the key thing was it put the focus on the behaviors, the trouble with attention, the impulsivity, not some assumed brain injury. That was a big step.
Okay, that makes sense. It sets the stage. So let's jump into how we define it today using the DSM-5. What actually constitutes an ADHD diagnosis now?
Right. So in DSM-5, it's classified as a neurodevelopmental disorder. The core definition is a persistent pattern of either inattention or hyperactivity-impulsivity, or both.
Persistent pattern.
Yeah, and crucially, this pattern has to be inconsistent with the person's developmental level, and it must interfere with their functioning socially, at school, or at work.
Got it. And for a clinician making that diagnosis, the source mentions 5 key criteria they need to check off.
Exactly. So first, some symptoms have to have been present before the age of 12.
Before 12, okay.
Second, those symptoms need to have lasted for more than 6 months. It can't just be a temporary thing.
Right.
Third is the symptom count. This is interesting because it changes with age. For kids, you need at least 6 symptoms in one of the categories, inattention or hyperactivity-impulsivity.
6 symptoms.
But for older teens, like 17 and up, and for adults, you only need 5.
Ah, that's a really important adjustment, isn't it? Recognizing that maybe the outward symptoms change a bit, but the impairment is still there.
Precisely. It acknowledges how the disorder can present differently as people get older. Fourth criterion, the symptoms have to cause problems in 2 or more settings.
2 settings,
Like home and school, or maybe work and in relationships for an adult. It can't just be an issue in one isolated part of their life.
makes sense.
And finally, number 5 is the exclusion rule. The symptoms can't be better explained by something else, like, say, a psychotic disorder or severe anxiety or depression causing focus issues.
Okay. And you mentioned comparing diagnostic systems earlier. That difference between the older ICD-10 and DSM was pretty stark, wasn't it? The ICD used to exclude ADHD if anxiety or depression were present.
Yeah, that was a huge difference. It meant that in big studies, like the MTA trial everyone refers to, only about 25% of the kids who met DSM criteria for ADHD actually met the stricter ICD-10 criteria.
Wow, only a quarter.
Yeah, they were essentially missing a huge chunk of the population we now recognize needs help.
Yeah.
Thankfully, the newer ICD-11 is much closer to the DSM-5 now. They got rid of that exclusion for anxiety and depression.
Yeah.
Though one difference still exists, ICD-11 doesn't allow an ADHD diagnosis if autism spectrum disorder is also present, whereas DSM-5 does allow for that comorbidity.
Interesting nuance. Okay, let's make this concrete for listeners. Can you give us some examples of what these symptoms actually look like? Starting with inattention.
Sure. For inattention, you're looking at things related to executive function problems, like making careless mistakes on schoolwork or at work, difficulty just sustaining attention on tasks or during play.
Like zoning out.
Yeah, or seeming not to listen even when spoken to directly. Losing things constantly, pencils, keys, wallets, paperwork. And a big one is actively avoiding tasks that require prolonged mental effort.
Right. The textbook specifically mentioned adults avoiding things like preparing reports, filling out long forms, or reviewing lengthy papers. I can see that.
Definitely. Then you have the hyperactivity and impulsivity symptoms. For kids, this is often the more obvious stuff. Fidgeting, squirming in their seat, leaving their seat when they shouldn't.
The classic running and climbing.
Right, running or climbing inappropriately. But in teens and adults, that often shifts. It might not be climbing the furniture, but more of an internal feeling of restlessness, like they always need to be on the go.
Okay, so it internalizes more.
Yeah. And the impulsivity piece includes things like blurting out answers before questions are finished, having real trouble waiting their turn, or interrupting conversations or activities frequently.
Got it. That paints a clearer picture. So now that we know what it looks like, the big question is, where does it come from? What causes ADHD?
Well, the textbook is very clear. It's complex. It's seen as a disorder with a multifactorial etiology, meaning it's likely a mix of genetic factors and environmental influences interacting.
But the genetic piece is really strong, isn't it?
Oh, incredibly strong. ADHD is actually one of the most heritable psychiatric disorders we know. The heritability estimates are consistently high, somewhere between 0.6 and 0.98.
Wow, up to 98%.
Yeah, it's huge. And the twin studies really drive this home. You see much, much higher rates of ADHD in identical twins compared to fraternal twins, like 59% to 92% concordance in identicals versus 29% to 42% in fraternals.
That's a massive difference. And what about family risk?
Also very high. First-degree relatives, parents, siblings, children of someone with ADHD are 2 to 8 times more likely to have it themselves. The risk is maybe 20–25%. And if a parent has ADHD, the source says about 50% of their kids are likely to have it too.
50%. That's incredible. And the research points to specific types of genes.
Yeah, a lot of the focus has been on genes involved with dopamine, like DATE1, and especially the DRD4 gene variant, which has links to things like novelty seeking and impulsivity. But it's not just one gene.
Right.
The current understanding, especially from genome-wide studies, is that it's polygenic, meaning lots of common genetic variations, each having just a tiny effect on its own, add up together to increase a person's susceptibility.
Okay, so lots of small genetic nudges. How does that translate to the brain itself? What's going on neurobiologically?
Well, the core idea is that ADHD involves issues functional and maybe even structural in a specific brain circuit. It's called the cortico-basal ganglia thalamocortical circuitry.
Whoa, okay, say that again slowly. Cortico.
Haha, yeah, it's a mouthful. Cortico-basal ganglia thalamocortical circuitry.
Right. And what does that circuit do?
Yeah.
In simple terms.
Think of it as like the brain's main control center or air traffic control system. It's heavily involved in regulating attention, planning, inhibiting impulses, and controlling complex movements, executive functions, basically.
Okay, the control center. And imaging studies show differences there.
They do. MRI studies often suggest some structural differences in areas within that circuit, parts of the frontal lobe, the striatum, the cerebellum, the basal ganglia, key hubs for attention and control.
But that finding about the developmental delay seemed really crucial in the text.
Absolutely. That's a key insight. Research shows that kids with ADHD often have a significant delay, like 3 to 5 years, in the maturation of their brain's cortex, especially in the frontal and temporal regions.
So their brain's control center is just developing slower in those key areas.
Essentially, yes. It's not necessarily a permanent deficit, but a lag in reaching typical developmental milestones for brain structure, particularly cortical thickness. Interestingly, this delay often seems to normalize somewhat with age and maybe even with stimulant treatment.
Fascinating. And this ties into the brain chemistry theories too, right? The neurotransmitters.
Exactly. The main working theory for decades has been the catecholamine hypothesis.
Catecholamines, like dopamine and norepinephrine.
Precisely. The idea is there's some kind of imbalance or dysregulation involving norepinephrine, NE, and dopamine, DA, in those key brain circuits. And this fits perfectly with why stimulant medications work.
Because they boost dopamine and norepinephrine levels.
Right. They increase the amount of DA and NE available in the synapse, the gap between neurons, which seems to help normalize the functioning of those attention circuits.
And what about other brain chemicals? The chapter mentions serotonin.
Yeah, serotonin seems to play more of a secondary role. We kind of know this because SSRIs, antidepressants that only affect serotonin, aren't really effective for the core symptoms of ADHD.
Okay.
And more recently, research involving things like glutamate, another major neurotransmitter, is starting to emerge, suggesting the picture might be even more complex than just NE and DA.
Always more complex.
Yep.
What about factors outside the brain? Environmental risks.
There are definitely associations, although proving direct cause and effect is always tricky with environmental factors. But things consistently linked include prenatal exposure to substances like alcohol and nicotine. Also, being born prematurely or having a low birth weight are risk factors. And then there are psychosocial factors, things like poverty, really negative parenting styles, maybe bullying. They don't cause ADHD, but they can certainly worsen symptoms or outcomes.
Right, they add stress to the system. What about diet? There used to be a lot of talk about sugar or food additives.
Yeah, that's been a controversial area. The chapter notes that while some studies suggested links, particularly with artificial food colorings, the FDA ultimately reviewed the data and concluded it doesn't really support a direct causal link between those additives and ADHD symptoms for most kids.
Okay, so the evidence isn't strong there. So
Yeah.
we have this complex interplay of genes and environment leading to differences in brain development and function. How
Yeah.
does this play out across someone's life? You mentioned symptom shift.
They really do. The hyperactivity piece is often the first thing parents notice, maybe even in toddlerhood. But that obvious gross motor activity, the constant running and climbing that usually decreases as kids get older,
It becomes less physical.
yeah, it often transforms into more of that inner feeling of restlessness in adolescents and adults. The fidgeting might stick around, but it's less overt. Inattention, on the other hand,
That sticks around more.
that often becomes more prominent a bit later, maybe around ages 8 or 9, when school demands really increase. And unfortunately, those inattentive symptoms tend to be more persistent throughout life.
So when we look at adults with ADHD, what does that restlessness and inattention look like practically? At work, at home?
Well, instead of running and climbing, it might manifest as difficulty unwinding or relaxing or feeling like they constantly need to be busy or doing something, that internal buzz.
Right.
And the inattention shows up as chronic problems with organization, time management, being late a lot, procrastinating on tasks, maybe having trouble keeping jobs. It can also strain relationships because the person might seem uninterested or like they aren't listening, even if they're trying.
That makes sense. And the textbook emphasizes this isn't something most people just grow out of, right? The prognosis is often chronic.
Yeah, that's a critical point. Studies suggest around 60% of children diagnosed with ADHD continue to experience significant impairment into their adult lives. The symptoms might look different, maybe shifting from a combined presentation to more predominantly inattentive, but the struggle relative to their peers often remains.
60% is a lot. And this leads us to another huge challenge mentioned, comorbidity. Other conditions happening alongside ADHD.
Absolutely. The chapter stresses that for people with ADHD, having other psychiatric conditions is basically the rule, not the exception.
Really? What kind of numbers are we talking about?
In childhood, something like 65% to 75% of kids with ADHD have at least one other diagnosis. Things like oppositional defiant disorder, ODD, conduct disorder, CD, anxiety disorders, mood disorders, learning disabilities are all very common.
Wow, 2/3 to 3/4. And in adults?
It gets even higher. Over 75% of adults with ADHD have at least one comorbid condition. Most commonly, you see anxiety disorders, depression, substance use disorders, and sometimes personality disorders.
That's incredibly high. And these co-occurring conditions must have a big impact.
A massive impact. The source notes that untreated adolescents with ADHD have a threefold higher risk of developing substance use problems. They also have higher rates of delinquency, more car accidents, and engage in riskier sexual behaviors.
It's serious.
And having conduct disorder alongside ADHD in childhood is flagged as the single strongest predictor of really severe problems later on, like persistent antisocial behavior, criminality, and even earlier mortality.
Okay, so managing ADHD is clearly not just about the core symptoms, it's about this whole complex picture. Which brings us to treatment. What's the overall approach?
The consensus, strongly emphasized in the text, is that treatment has to be multimodal. It needs to target both the ADHD symptoms and any co-occurring conditions, usually combining medication with psychosocial or behavioral interventions.
Right, let's start with the medications. The book calls stimulants the gold standard. Why is that?
Primarily because they have decades of research showing they are highly effective and generally safe when used properly. They produce really significant improvements, what researchers call large effect sizes, around zero point 0.8 to 1.0 on measures of behavior and attention.
And they help with real-world outcomes too, right?
Yes, studies suggest they can reduce things like academic failure, accidental injuries, later substance use, and even involvement with the criminal justice system.
Okay. We have the two main types, methylphenidate, like Ritalin or Concerta, and amphetamines, like Adderall or Vyvanse. What's the difference in how they work?
It's subtle but important. Methylphenidate, MPH, mainly works by blocking the reuptake of dopamine and norepinephrine, basically stopping the vacuum cleaner that sucks them back up so more stay in the synapse.
Okay, plugs the grain.
Kind of. Amphetamines, AMP, do that too, but they
Hmm.
also actively push more dopamine out of the neuron, so they're generally considered a bit more potent, though effectiveness varies hugely from person to person.
Which is why treatment needs to be individualized.
Exactly, and that includes choosing the right formulation. You have short-acting ones lasting maybe 3-6 hours, and long-acting ones designed to cover 12, even up to 16 hours, depending on the person's needs throughout the day.
What about the downsides? What are the common side effects people worry about?
The most common short-term ones are things like decreased appetite, some difficulty falling asleep, maybe headaches or stomach aches, especially when starting or increasing the dose. These can often be managed by adjusting the timing or dosage or ensuring the person eats before the meds kick in.
Okay. And the text mentioned something called rebound.
Yes, rebound. That's when the medication wears off, often in the late afternoon or evening, and the person's behavior actually gets worse for a period, more irritable, more hyperactive than usual.
How do you manage that?
Usually by either switching to a longer acting medication that wears off more smoothly, or sometimes by adding a very small dose of a short acting stimulant late in the day to sort of ease the transition off the medication.
Got it. And the big long-term worry,
Mhm.
especially for parents, growth. Does it stunt growth?
That's a common concern. The evidence, like from the MTA study, suggests there can be a small effect on growth rate, particularly in the first year or two of treatment, maybe slowing height gain by about 1 centimeter per year on average.
1 centimeter.
Yeah. But the data also suggests this effect might lessen over time, and much of the lost growth seems to be caught up later, especially if clinicians use planned drug holidays.
Drug holidays. Like taking breaks from the meds.
Exactly, often during the summer or weekends, specifically to allow for potential catch-up growth. And importantly, regarding another long-term fear, the text reinforces that starting stimulants in childhood does not seem to increase the risk of later substance abuse. If anything, treating ADHD might be protective against it.
That's a really important point to counter the myths out there.
Yeah.
Okay, so stimulants are first line. What if someone can't tolerate them? Maybe they have bad anxiety tickets that get worse.
Then you move to the non-stimulant options.
Oh.
The main one discussed is atomoxetine, brand name Strattera. It's an NRI and norepinephrine reuptake inhibitor.
So it works differently than stimulants.
Right, it only targets norepinephrine. It provides 24-hour coverage, which is nice, but the big difference is it takes time to work, usually 1 to 4 weeks, to see the full effect, unlike stimulants, which work almost immediately.
Takes patience then.
Definitely. And you have to increase the dose slowly because people metabolize it very differently based on their genetics, specifically an enzyme system called CYP2D6.
Ah, that enzyme thing again. So dosing needs care. Any other non-stimulants?
Yes. The other main class are the alpha-adrenergic agonists. These are medications like long-acting guanfacine ER, Intuitive, and clonidine ER, Capfe.
How do they compare?
They're generally considered less effective than stimulants for the core ADHD symptoms, maybe moderate effect sizes. But they can be quite useful, either alone or added to a stimulant, especially if there are issues with significant oppositionality, aggression, or tics.
But there are cautions with those too.
Yes, a big one is sedation. They can make people drowsy, especially initially, and you have to be very careful when stopping them. You need to taper off extremely slowly to avoid something called rebound adrenergic overdrive.
Adrenergic overdrive. What's that?
It's basically your system going into hyperdrive because the medication that was calming it down is suddenly gone. It can cause dangerously high blood pressure, agitation. It's serious. So, slow taper is essential.
Good to know. Okay, we've covered meds. What about the non-medication side? The psychosocial stuff?
Crucial part of the multimodal approach. For younger children, especially preschoolers, behavioral interventions are often the first line, even before medication. This usually involves parent training and behavior management techniques.
Like setting up reward systems, consistent consequences.
Exactly. Things like token economies, contingency management. For older kids and teens, these behavioral strategies are important adjuncts to medication. For adults, the strongest evidence is for cognitive behavioral therapy, CBT.
But CBT tailored for ADHD, right?
Yes, specifically adapted to target the challenges adults with ADHD face: problems with organization, planning, time management, procrastination, and sometimes social skills difficulties stemming from inattention or impulsivity.
And things like academic coaching or workplace accommodations.
Absolutely. Academic organization skills training, social skills groups, and importantly for adults, understanding their rights to reasonable accommodations under laws like the Americans with Disabilities Act, ADA, can make a huge difference in functioning.
Okay. And pulling back to the comorbidity issue, if someone has ADHD and severe depression, for example,
Yeah.
how do clinicians decide what to treat first?
The guiding principle, which the chapter connects to approaches like the Texas CM-BAKE algorithm, is generally to treat the condition causing the most severe impairment first.
So stabilize the really disruptive condition before tackling the ADHD.
Right. If someone has, say, active bipolar disorder or severe untreated depression or anxiety, you typically need to get that under better control before introducing a stimulant, which could potentially worsen mania or anxiety if not managed carefully. It highlights why you need that comprehensive multimodal plan. Medication alone rarely cuts it for all the associated problems.
That makes perfect sense. So if we try to boil down this whole deep dive,
hmm
what's the core takeaway from Kaplan and Sadock on ADHD?
I think it's that ADHD is fundamentally a highly prevalent chronic neurodevelopmental disorder. It has a very strong genetic basis, leading to differences in brain circuits that control attention and impulsivity.
And it causes real, significant impairment across life, school, work, relationships.
Definitely. Which means it requires long-term management tailored to the individual, using a combination of medication and psychosocial supports, always keeping an eye on those very common comorbid conditions.
Okay. Before we wrap up, do you have a final provocative thought for us based on this chapter?
Well, one thing that struck me is the discussion around remission in adults. Often when studies report adults remitting from ADHD, it's partly because the diagnostic criteria require fewer symptoms for adults than for kids.
So they might still have significant issues, just not enough to meet the full childhood criteria anymore.
Exactly. They might fall below the symptom threshold, but still struggle quite a bit with organization, focus, restlessness, those subtle impairments. So the thought is, if true functional remission is less common than symptom count remission suggests, what are the real long-term costs, societal, economic, personal costs, of potentially underdiagnosing or undertreating these persistent adult impairments?
That's a heavy question. It really makes you think about the definition of remission and what treated truly means long-term.
Yeah,
A lot to mull over.
indeed.
Well, thank you for guiding us through that dense material. And thank you, our listeners, for taking this deep dive into the source material with us today.